All right. Hello, everybody. My name is Benjamin Day,
And I'm Jillian Mason.
and this is Medicare for All, the podcast for everybody who needs healthcare.
That it
So,
is.
Jillian, as you know, because we are both patients and we both have endless patient stories between the two of us, more than I would ever want. I think probably almost every patient in America has had, a frustrating experience in a hospital setting where we feel like we're on like a medical conveyor belt that moves way too slowly,
Oh, yeah.
like we sit too long in a waiting room, then we're spoken to maybe way too briefly by our nurses or doctors, and we feel like we're filling out more an online survey than that we're really being listened to. Sometimes we have to do more waiting at that point, and then we're pushed on to the next specialist or appointment too quickly. And of course, that's almost like a best case scenario. Some patients experience far worse disasters in hospital settings. Now, as patients, we know that there's a dysfunction going on there, and it leads a lot of people, I think, to kind of distrust medical providers, maybe to avoid healthcare altogether.
Yeah.
But the nurses and doctors and medical professionals themselves know that, behind the scenes, they are being pushed to the brink by hospital corporations and our healthcare system. And they're not really being allowed to treat their patients to the best of their abilities. So today we're going to focus on kind of one of those most crucial behind the scenes hospital policies behind our bad experiences as patients, and that is staff to patient ratios. And we have a guest here, an amazing guest who's going to explain both what that means and why it's so important, even if it's something that we as patients don't see at all. We might not know what our patient ratios are at a hospital, or we might not know that something is going wrong there. So do you want to introduce our guest, Jillian?
Oh, would I ever love to? All right. So we have Gerard with us. Hey, Gerard, thank you so much for joining us.
Oh, a real pleasure to be here, Jillian. I'm Ben.
Oh, God, listeners, do you hear that accent? It's wonderful. So we have here Gerard Brogan, and he has over 40 years experience as a nurse. He's practiced nursing in the U.S. since 1984 before joining the California Nurses Association in 1994 as a nursing practice representative. He's the director of the nursing practice department for the California Nurses Association / National Nurses United. Shout out to the Nurses Union. We love y'all. Gerard has extensive experience in staffing ratio legislation, which is why we brought him here today, because he was actually part of the successful campaign to establish nurse to patient ratios in California. And he has subsequent experience in seeing the efficacy of how that law actually benefited patients. So he serves as an educator for the organization. He teaches classes to nurses on a variety of topics relevant to healthcare in general, and the scope of nursing practice and patient advocacy in particular. That is a mouthful, but thank you so much, Gerard. We are so happy to have you here.
No, happy to be here.
Yeah.
Ben, do you feel like Gerard is like maybe one of our more distinguished guests?
I mean, we don't get a lot of 40-year CVs here, so
Yeah.
I'm impressed. But before we ask you about your experience in the, both from the bedside perspective and also from the policy perspective, I just want to ask you, why did you first become a nurse? When you started, presumably in the UK.
Yeah, and it was in the UK. I think it's a fairly common story that I'm about to state. I was 19 years old. I'd had some issues with authority. I just want to put that on the record. So,
welcome to the club.
Yeah, which has served me well, actually, in this role. But, I was a bit of a lost soul, as often teenagers are, looking for direction. What am I going to do with the rest of my life? I wanted a job with meaning. I didn't want to go to a place that made widgets that I'd kind of get alienated from. And interestingly, I was an avid reader when I was very young. And I read One Flew Over the Cuckoo's Nest when I was 11. And it had a profound effect on me.
Wait, did you want to be Nurse Ratched? Was that the
No, no, that was a poor illustration of the. Obviously, it was a symbolic role, as you know.
Fair.
So that had really stayed with me. I was dating somebody at the time whose father was having a midlife crisis and was looking for meaning himself, and he was looking into being a psychiatric nurse. So I read the paraphernalia, the pamphlets he'd got. I thought, well, there you go. That would be a meaningful life. And that was it. So I applied to several nursing schools. I was accepted, and there you go. And I've been a nurse ever since.
That's awesome. Super
long time.
cool. Love to hear it, and love to hear that Ken Kesey has been motivating people to become a nurse, which is nice. That's awesome. So, some of our listeners are healthcare providers, and they will certainly be already familiar with this topic of safe staffing that we're going to dive into here. But most of our audience are folks who experience the healthcare system as patients. And so I guess the question I wanted to kind of start out with is, like, why should people who are patients care about safe staffing, and how do we see unsafe staffing practices show up when we're at the hospital waiting for care?
Okay, well, there's one good reason. There's many reasons why consumers or patients, we're being rebranded as consumers of healthcare, which says a lot, right?
Yeah, we don't like that.
Not a service. You have less chance of dying in a hospital when ratios are adequate and guided by the registered nurse's professional judgment. And I'm going to fold doctors into some of my responses. Doctors and nurses should be making the clinical decisions. They shouldn't be made on a budget. Sadly, in a for-profit healthcare system, as we all know, they are made by budgetary concerns. So, one, you've got less chance of dying. Two, you've got less chance of a poor patient outcome, errors. Obviously, the less staff you have, the more prone that system is to errors. And you've got, interestingly, things like less chance of being readmitted to hospital because it wasn't done correctly in the first place. And that actually saves hospitals money. CMS pays a lot of money to hospitals for readmission rates. They'll ding you if they're high. So you get better care, to hone it down to a very simplistic answer, you get better care if you've got the correct nurse-patient ratios.
And so we know that in parts of the country, in most of the country here, that staffing ratios are not safe. How do you think that patients might sort of see that or experience that when they're seeking care?
Well, I'm going to echo what Ben said right at the start, introducing this particular podcast. And just echoing some of Ben's comments when he said, we all know the frustrations, long waits in the ER. You get interviewed by a nurse or a doctor and it just feels, it's not really clinical. They're not treating you as an individual, not looking at the socioeconomic background, all these factors that influence, as I'm sure many of your listeners know. Everything affects your state of health and your access to health. So that's the real reason I think people should, patients, and everybody's a potential patient, obviously, should care about nurse to patient ratios. Ever since its inception, the nursing profession, around about 1850, we've had a holistic approach to care. And that is, we will look at the whole human being. And again, I'm not going to give a lecture on that, but I'm sure people know what I'm talking about. Looking at every aspect of that person, which takes time. And it's time that the industry does not want to give you as a patient. And we'll probably discuss some aspects of that during this podcast.
Yeah. Right. So when I'm sitting when I come into the ER and I'm put out on a gurney in the hallway for several hours, right? I shouldn't be thinking, where's that nurse? I should be thinking, where's that CEO who didn't staff enough nurses at this hospital, right?
Absolutely. Nurses get the brunt because we spend the most time with the patients. And I want to include our colleagues, nurses' aides. We're the hands-on professionals. So we get the brunt of the complaints from patients. And I've often said, and it's not really tongue-in-cheek, we should all have a little card with directions to the CEO's office.
Right.
Hey, yes.
Seriously.
Oh, I love that.
So that, and then instruct the patients, yes, sorry, you're not getting the optimal care that we should be providing you. And here's who makes those decisions. Because those decisions are made in the abstract by these folks.
Absolutely.
And patients' pain, you know, let's stick to the ER. The dreadful things you see in the ER, they're certainly not an abstract to that patient, and they're certainly not an abstract to the nurses and the doctors caring for those patients.
Yeah.
Well, not dying is that's a compelling case for for a policy change. I might be sold, but I also wanted to ask you. You started talking there about not the patient's perspective, but how nurses experience staffing shortages and inadequate staffing. And having worked with first the Massachusetts Nurses Association for many years here in Boston, and then National Nurses United when I kind of moved up to the national scene with Medicare for All. As far as I can tell, trying to improve nurse staffing levels has been like the #1 priority of nurses unions all across the country. More of a priority than nurses' wages or benefits like their own healthcare coverage, their retirement contributions, the things that almost all unions are focused on, and even non-union workers kind of focus most on when they're looking at jobs. So why is it from the perspective of a nurse that staffing levels are so urgent and just such an existential issue for nurses?
Yeah, it's a great question. And I actually want to state, you mentioned union nurses, and then you did mention other nurses. It's a hue and cry from every nurse's lips right across this country, no matter their political stripe, whether they're unionized or not. And I can expound that globally. You know, we're part of Global Nurses United. That's a group of us, I think 27 different countries now belong to that. Obviously, I keep in touch with folks in the UK, and it's staffing is their major concern. And the main reason is, again, often in my classes, I will ask the audience, did any of you get into this job for the glamour?
Blood and guts.
Interestingly.
Just looks really good in scrubs, you know?
Yeah. So, because it's not a glamorous job. It's a dirty job. You know, it's an intimate job. I'm not going to go into the details of those intimacies, but you all know what I'm talking about. So again, most nurses come into this for idealistic reasons. And sometimes it's that vague, I just want to help other people. Sometimes it's a little more refined. So it's anathema to a nurse to go into any workplace setting, whatever unit or facility they're working in, to be sped up, and that's out of their control. They are still responsible and accountable for the patient outcomes of those patients under their care. So we've looked at this a great deal. Obviously, we're a sophisticated organization. We have a research department that look into all these issues. And just every nurse wants to be a patient advocate. It's part of our ethos. We're lucky in many states, such as California, we are legally obliged to be a patient advocate. We're not there to look after the business interests of our employers. We're there to provide the optimal care when that cannot happen. And again, I can expound this to every healthcare worker. We get moral distress. There's been a controversy the last few years of the industry and its aiders and abettors talking about burnout. We do not like the term burnout. It implies some kind of personality defect. It's moral distress. And we've seen a lot of research on this, been a lot of research with our veterans on this, I'm happy to report. And a lot of this research shows the same level of moral distress with veterans in foreign wars. You know, obviously some of the things they have to do that they're not in control of, and nurses and other healthcare workers. So You want
Wow,
to do the right thing, but you're constrained by forces beyond your control not to do it. This can lead to PTSD, and we're seeing a lot of that. Obviously, being an organization that advocates for nurses as they in turn advocate for the patients, we're doing a lot of work on that particular issue.
That is such an amazing and profound statement of why nurses are so amazing. And it so tracks with all the people in my life who are nurses. Shout out to my sister Emily, who's a nurse
Emily.
at Boston Healthcare for the Homeless. And all I ever hear her complain about, she never complains about the stuff that impacts her. She doesn't complain about her own health care or her pay or anything like that. The only thing she ever complains about at work or anything that would stop her from treating a patient.
Yeah.
And that makes a lot of sense. Yeah.
And I have
really are in it.
Echoing Jillian there, I have an aunt Cheryl who's a nurse, and she said she's the only one from her class, her nursing school's class, who is still in practice as a nurse, and everyone else has left for, I think, reasons kind of like you described. Can you give us a sort of a real life example of a staffing level that you've heard about in a department that was unsafe, and then what you, like the NNU, recommends as a safe staffing level?
Yeah. Okay. Yeah, here's a good example. Texas, and I believe Jillian's now currently living in the great state of Texas.
Yep.
So I happily, and I mean that, I like traveling across this great country. I've done a lot of classes in Texas.
Okay.
So in California, since 1976, okay, so that's a long time ago now, almost getting close to 50 years, we've had in law a ratio for ICU patients, that a nurse in an ICU cannot legally take care for more than two patients, and often only one, depending on the severity of the patient's illness. So I'm in Texas, I'm asking them about what are your ratios in the ICU? Hands up. I took care of 5 patients 2 nights ago.
Wow.
Oh, Jesus.
Yeah. And along with that statement come tears, which takes us back to the moral distress of this nurse. This nurse is so upset. I cannot cope with this. So what we do is we believe in unionism, of course. So then we talk about organizing, because that individual nurse cannot fight that by themselves. And Texas is notorious for blacklisting nurses.
Yeah.
Any nurse who speaks up, we see that again, mainly in predictable states, and I'm talking about the red states in the South. Where a nurse will be vocal, try and advocate for those patients, and then all of a sudden they'll find some charting error. You can fire anybody for anything if you really intend on doing that. So we'll do that, and then we'll also talk about, well, let's go on a campaign to bring nurse-to-patient ratios to Texas, which we have done. We failed to do that, but that doesn't mean we're not going to come back. It took us 13 years to pass the ratios in California. We know this is a long-term project that takes stamina to stay in the game on this.
Yeah. Those ratios are wild. I'm thinking of that 1 to 5 ratio.
Yeah,
Ben just got married last month, and in his groom's party, he had 4 people. And now I'm thinking that like Ben was better staffed at his wedding than most persons.
Yeah, well, I'm not likening Ben to a dog, but dogs in kennels have better staffing ratios than patients in acute care hospitals.
Whoa. Oh, that's brutal.
And probably states are happier to regulate dog care than they are human patients in hospitals.
Damn. That is rough. So, you brought up the issue of you'd brought up, this issue of staffing and just how, kind of excruciating it is right now. And you talked a little bit about how that's developed over time. Why is it, right, that at this point we're hitting this kind of crisis moment with staffing levels? Why are these hospitals skimping on, of all things, nursing care?
Yeah. A little bit of history. So, and you can ask any nurses of my age who were working in the 80s and then in the 90s, sea change. So I worked for the Sloan Kettering Cancer Center in New York, starting in 1984. Staffing was impeccable. The Sloan Kettering is a very rich institution. You know, the ladies who lunch on the Upper East Side give it a lot of money. You know, it's a thing. And it was great. We did primary nursing, where I was a consistent nurse for a specific set of patients. So you got that continuity of care. You could establish those relationships. Then I moved to California, and I worked for the University of California. Again, an incredibly wealthy institution. Staffing was great. I used to call it workers' paradise. It was fabulous. I had a lot of autonomy. I was a charge nurse on a psychiatric unit there. I could refuse admissions. I got full respect for my professionalism, and I was allowed to have this autonomy. 98, Bill Clinton's president. Hillary Clinton tries to reform healthcare. Some of your readers, listeners my age will remember this. It failed, massive campaign against it. Bill Clinton goes on TV subsequently to that, puts his hands up in the air and said, "We tried to reform healthcare, we failed, let the market decide." So,
yikers.
The market jumped at this. There was about 3.4 trillion being put into healthcare at the time. We can go in, and you know how these folks think. We'll bring in efficiencies.
Efficiency is always a code word for fuck you. Right?
Yeah,
like,
exactly. You use that crude word, not me.
Oh yeah, pardon
Yeah,
my
no, you've got it right on that. So I saw this at UC. It started to change. The whole zeitgeist started to change. We started getting money from pharmaceutical companies, and I could go on, but I think that's the main issue. Then we saw everybody flowing into healthcare, HCA healthcare. That criminal Rick Scott came out with a lot of hyperbole, and then got the largest fine for Medicare fraud. I think it's $5 billion. And now this guy's a politician. You can't make these things up, right?
So now that leads me to now I'm curious, because a lot of people think for-profit and not-for-profit hospitals. We both know they're both problematic within the current healthcare system, and sometimes it can feel like a non-profit hospital is acting just like a for-profit hospital, still kind of looking out for their bottom line. But do you observe a difference on staffing ratios? I mean, for-profit hospitals have to get those profits from somewhere, which means it's got to be cut out of somewhere in the care system. Yeah. Do you see a difference, or is it equally bad across kind of both sectors?
Sadly, it's equally bad, because the non-profits emulate what the profits do. They all belong to their state hospital associations. I probably don't need to say much about their philosophy, certainly on staffing. So no, we don't see that. Kaiser, I don't know how big it is on the East Coast. It's really big on the West Coast. Is a non-profit. It just happens to generate a lot of excess revenue, right? In the billions.
Not profits at all, just excess revenue.
You know, there's a lot of wordsmithing in all this, but they all belong to the same organization, and they all have the same intent. And a lot of that is really insulting what nurses do. You know, there's a school of thought out there. I'm going to simplify it. It's just a bunch of women, right? Female-dominated profession who are kind to patients. There's not a level of sophistication in there. Why are we paying them these exorbitant salaries?
Ugh, such bullshit. I'm really glad you brought in the gender component too, because that is such a big part of it, right?
Oh, it's utterly part of it. Again, I'd like to claim I wrote this, but I didn't. Well, we've got a huge piece of research and subsequent reports on that called the care penalty, which talks about how every female-dominated profession has been short-shifted in terms of salary and esteem. And obviously, this is to change. And again, the Guardian a couple of years ago put out a report. They estimated, and really good research, that around the world there's about $4.2 trillion of value added by carers across the world.
Wow.
and it is not compensated.
Yeah. Wow.
You know, it adds to the economy, of course, on and on and on.
And as you went through that timeline of kind of how things started to change in the
Yeah.
80s and 90s, I was reminded, I've heard a lot of people talk about how the administration of hospitals started to shift from, you would have doctors who kind of rose up the ranks within their hospital,
Yeah.
became the heads of their departments, and then maybe were running their hospitals as CEOs, but they started to be replaced by Harvard Business School MBAs who, you said at the very beginning, you got into nursing because you didn't want to make widgets. But
Yeah.
now the guys who are running hospitals, and they're mostly guys, are treating hospitals a lot like a widget manufacturer. So it sounds like maybe similar.
Yeah, they're using, I don't know how familiar your listeners are with Taylorism, came in during the Industrial Revolution. And again, it's all about this word efficiency. Toyota have this apparently brilliant method of making cars, but it's a car. It's not a human being. And let's face it, we're messy things, right? Because we have these things called emotions and feelings, and all that's kind of out of the window. Quick anecdote about a Harvard MBA. I was a long-term charge nurse at UCSF. Young whippersnapper MBA from Harvard came in, real arrogant, and we had a meeting with all the charge nurses, and he was going to tell us, my blood pressure's raising right now. Calm down. He was going to tell us how to talk to patients.
Oh my God. Yeah. Okay, great.
Yeah.
How did that go?
Well, he got slapped down, not just metaphorically.
Of course. Nurses are nonviolent people.
A couple of those pesky women stood up and,
I'm from Boston, so I'm contractually obligated to shit on Harvard at least once per episode. So thank you for helping me.
You got it right in one, Ben. It's they come in, they have no idea. They're looking at the bottom line. It's just this clash. There's a graph I use in classes of the amount of doctors in hospitals from like 1988, and then administrators.
Right.
Are you all familiar with that?
I've seen this one. PNHP uses this one too.
It says it's kind of end of lecture when you see this. Just admin. Right. This for-profit system, obviously Medicare for All folks know this, 20% is spent on admin, advertising, hyperbole, competition. That's 20. Yeah, just nonsense really that could be going into clinical.
Yeah, and we haven't even gotten to COVID yet. Because obviously COVID, the pandemic, really profoundly impacted the whole healthcare delivery system in every country, but I think particularly dramatically here in the U.S., where we don't have a national healthcare system. We have no ability really to plan across the system or to respond to emergencies on a nationwide basis. So what does the kind of post-COVID landscape look like for nurses, particularly from staffing perspective?
Yeah, challenging. Just a real quick word on the pandemic. The World Health Organization in the mid-1990s, mid-2000s put out copious, and I'm not exaggerating, copious guidelines about the coming pandemic. In the medical field, we all know it was never if, it was always when. So the guidelines were there to have this amount of PPE. This is how you mitigate it. These are the public health protocols you put in place. This is how you talk to the public about it. Did the for-profit healthcare industry in this country take notice of that? Not one bit. Right. I always use the example of those egregious photographs we saw when New York City was the epicenter.
Right. Yeah.
And nurses and doctors going into patients' rooms with garbage bags.
Right.
They're just so. To answer your question more fully about post-COVID, for a lot of nurses, a lot of doctors, it's the final straw. Again, we talked earlier about AIDS patients. Well, we talked offline about that, and our nurses did not balk at going in that room when it was an unknown disease. How do you catch it? Same with COVID. Nurse after nurse after nurse spent hours in those PPE suits when they could get them, just caring for these patients. And again, it was a very ugly way to die. You just not being able to breathe. So they met their tacit social responsibility to the patients, whereas the employers failed to meet their tacit social responsibility with the staff. So what we're seeing now is this hue and cry from the industry. Well, we've got a nursing shortage. It is not a nursing shortage. 4.4 million nurses currently licensed in this country, 3.3 million of them working. So the industry never let a crisis go to waste, right? So they're really jumping on that. So now what they're talking about is we need to go back to team nursing, where we'll have one nurse supervising a bunch of lesser trained, lesser educated, and no offense to them, but so we don't have to pay them as much. Or we'll start gig nursing now. This is a huge thing now, where you can be your own boss. You will dictate when you work. We know you burn out. Come and join our gig company. Life will be great. You've got this autonomy and freedom. Well, we've talked to Uber activists.
Right. I was going to say, that sounds familiar.
Yeah. And they tell us, no, the algorithm is in charge of you. But egregious things, as part of this, and again, we could talk for hours about this. So they're trying to seduce nurses to become as mercenary as they are, frankly. Lots of nurses will not go back to the bedside. They said, this is the final straw. It was insulting. I put my life on the line. Story after story of nurses sleeping in an RV in their driveway because they did not want to go in the house because of their family. Give them that. So we're slightly concerned about this because nurses have had enough. It's been like the final straw for them. Nursing is an inherently stressful occupation, and it was only compounded and amplified by COVID. So to me, this is the real tragedy of this. You've got this cohort of people who want to do the right thing, who have just been treated so egregiously that, look, they're not saints. We are not saints. We're just regular human beings. And again, the industry's taking great advantage of this. If you want to bring in telehealth, where any nurse from any state can provide this telehealth, they're really keen on this. Why? Increases profits. And again, we warn our members, some nurses kind of like this when they first see it. But when we take them through the ramifications of this, you're not going to pay a nurse in a heavily unionized Bay Area 67 that care. You're going to go to Tennessee for $18 an hour. Again, the folks behind this, and this is not an exaggeration, are looking at an international licensure.
Wow.
You won't be paying a nurse in Tennessee $18 an hour. You'll be paying a nurse in Latvia. Sorry, anybody's from Latvia, but $4 an hour. It'd be like the garment industry. You will be chasing the cheapest labor force right across the world.
Jesus Christ, that's depressing.
It is.
Okay, maybe this will be slightly less depressing. So you had mentioned that in California, right? California has actually been practicing safe staffing for many years. What exactly has that looked like, and what have been the things that folks have learned about the importance of safe staffing from seeing what's happened in California?
Several things. One, I'm going to repeat it, less people die. Patient outcomes are better. You actually get discharged quicker if you've got the right amount of nursing care, which is... There's a business case for ratios. And
less wait times, I imagine. For
less wait times, every single aspect, less turnover. So we're challenging now this new paradigm brought on by the industry you need to retain the nurses that you've got. And the best way to do it is to have nurse to patient ratios. Quick stat. A Texas university looked at nursing turnover rates in 2017. Texas, 21.7% turnover rate. So you're a CEO, you're the bean counter. 1 in 5 nurses is going to leave. It's going to cost you between $45,000 and $80,000 to recruit, retain, orient a new nurse, right?
Yeah.
It's a terrible business decision to treat the nurses better.
Mhm.
Florida, 16.7%. New York, 8.5%. Heavy unionization, right? California, turnover rate, 3.2%.
Wow.
Whoa.
That's incredible.
Because
Yeah.
of the
That's a
ratio.
dramatic statistic.
Mhm.
It's
Wow.
an incredibly dramatic statistic.
Wow. Oh, that's a good one.
Yeah.
So in general, then we see that safe staffing does actually work, like you were saying, not just at a moral level or at the level of public health, but also at a kind of capitalist, like by their own capitalist logic, right?
Exactly, and well encapsulated, Gillian. It's mind-boggling that they don't embrace it. But again, I'm sure many of your listeners are political folks. It's all about power and control. That's always
And Gerard, I live here in Massachusetts, where safe staffing was on the ballot not that long ago. So everyone in our state has been flooded with propaganda by the hospital industry. And a couple things I wanted to ask you about that. One is they will put nurses on TV who are actually nurse managers.
Oh, yes.
Who will talk about the impact on nurses.
Yeah,
I wanted you to maybe disabuse people of the notion that every nurse they see on TV is actually a bedside nurse. But also, of all the scare tactics and things that they say, I think the number one is they claim that it will force hospitals to close their doors, basically. Or shut down massive services that it just means they'll be bleeding money. Did any of that happen in California when they first implemented the safe staffing ratios?
This is another blood pressure raise for me. No, seriously, they're outright lies. I mean, it's just bold-faced lying. Not one hospital closed in California. And in fact, some of the major systems like Kaiser I've referenced and UC, after a couple of, they fought against the ratio law, of course. After a couple of years, they said, well, you know what, it's actually working.
Right.
We're not losing money. They claim there's long waits in the ER. We've looked at the research. California does not have longer waiting times in the ER than any other state. And again, we're highly aware of the Massachusetts. We did a lot of work with our colleagues in Massachusetts. They were outspent. And as we know, any initiative, 93% of who wins is the person who spent the most money on it. And here's the thing about these so-called nurse leaders. They all belong to this organization called the American Organization of Nurse Leaders. And they share offices with the American Hospital Association. It's pretty blatant. If you look at their website, we look at healthcare issues from the perspective of the employer. And again, my face is pretty red because I'm in a red room. It's violently red. They literally dressed themselves up and pretended to be frontline nurses.
I can remember during that campaign, a woman who worked with one of the nurse leaders who was on a TV commercial was like, that bitch was in that commercial wearing scrubs. I have never seen her in scrubs in her life.
Yeah. I forgot to mention Jillian was in Massachusetts at that time. Was working on that campaign at Mass Justice as well. So we both saw it. Yeah.
We discussed it internally. And, I was one, sometimes I'm a little more aggressive than my colleagues. We should report them to the Board of Nursing for fraud. Just outrageous. But, sadly, money, well, to quote Bob Dylan, money doesn't talk, it swears, right? And it certainly swore in Massachusetts.
That's besmirching the good name of swearing.
Yes.
But yes.
So we had one final question for you, which is obviously California. Thank God we have this case study that can kind of disprove a lot of the crazy claims about what happens if you regulate safe staffing ratios. But tell us a little bit about what happens if we win a Medicare for All system. We actually have a national health plan, a national insurance plan. What is it like? I'm sure it's not perfect in countries that have single payer healthcare, but it must create a framework where the country can say, well, we want certain basic safety levels in in all provider settings, and we can barely do that right now. So we don't do it.
Well, I certainly know on the national level, and in various states where Medicare for all, single payer, as you all know, there's different names for it. Ratios are part of that in the federal bill. And again, so just going back to what I said earlier, about 20% is spent on admin. In countries with single payer, it's between 7 and 11%. Again, quick personal note, I was shocked by the inefficiencies of the American healthcare system when I came over. Because, I'm not unsophisticated. Well, I like to think so.
You do have the accent. That's sophistication.
I thought, well, America's a mean, lean, capitalist machine. So, they're really efficient. And I saw these tons of inefficiencies, paperwork galore. I thought, well, this is like communist Soviet Russia, like this and that, asking patients, and this kills every nurse who emigrates to this country. Are you insured? Before you ask them anything else. So that money can go towards clinical staff, research, put the clinicians back in charge of the care, not giving these, administrators. Again, really want to stress it's abstract to them. As part of our ratio campaign, we ran a managed care was getting a really bad name in the early 1990s. 1994, we came out with a campaign for single payer in California. And we took on our mantle as patient advocates. So we allied ourselves with patients. We put ads in a lot of major newspapers, no email back then. We were inundated with people's horrific stories of undermanaged care. We were overwhelmed. It became my full-time job for 2 years. But we allied ourselves with the patients. And even politicians are human beings. So every time we went to the legislator, patients were there with us talking about what had happened. And, I don't want to make this too grim, but, the death of children, the death of... The one that sticks out in my mind was one chap called me, and his wife told me the tale. He was trying to get admitted to a Kaiser hospital. And because they refused him, he actually had a heart attack while he was trying to get admitted to hospital. And he was taken to another hospital. So we were seeing all these kind of things back then. I'm not sure that answered your question, because I think I went a little off piece there.
No, but it sounds like Medicare for All has, both, obviously, if the legislation has ratios, that's going to help quite a bit. Because I think Medicare for All, it's really just changing who pays the bills, which sounds like an abstract, distant thing that won't matter that much. But it does have these profound impacts downstream on providers. So
absolutely. It puts providers back in charge. People try and defend the American health, for-profit. Well, we pay for research. Well, that's baloney. Research has gone on in England, amounts of research, effective research that's gone around the world in a government-sponsored healthcare system. And again, I really want to refute one myth. And I used to say this to patients in the NHS. This is fantastic. I can't believe the care I'm getting, and it's all free. And I remember, no, it's not free. We all pay in so that when one of us has a crisis, it's free at the point of access.
Right. Yeah.
So sane, so rational.
I know.
Well, thank you so much for joining us. This is one of those things that, if you just experience the healthcare system as a patient, it's going to be mostly invisible to you, but it's so important for how we experience it. And
Absolutely.
Our chances, as you say, of even making it out of the hospital once we get in, if it's a very urgent situation. So Healthcare Now, we're going to be there with NNU in this fight for safe staffing and for Medicare for All. Thank you again so much for joining us.
Look, anytime we can talk about these issues, we're happy to do so. And Ben and Gillian have been good to me. I can't see any of your listeners, but
They'll be
been an informative.
Yes.
Awesome.
Thank you so much. And I should also thank our podcast team, without whom we could not do this podcast. Our Podcast manager is Angelique Davis. Our show notes writer was Jerry Katz, who works for the Minnesota Nurses
Yeah,
Association.
Jerry. No, Jerry.
Yes, and our audio editor was Christian Brandt. So don't forget to like this episode, subscribe to the Medicare for All podcast on whatever your favorite podcast platform is. And this show is a project of the Healthcare Now Education Fund. So if you want to support our work, you can donate at our website, healthcare-now.org. Thanks all. We'll see you in a couple of weeks. Bye.
Stay safe and stay dangerous.